Welcome to the 2013 Sedation Peer-to-Peer Podcast. This educational activity is sponsored by the France Foundation and is supported by an educational grant from Hospira. Today's discussion is presented by Dr. Girard and Dr. Balas. Let's listen in.
So, Tim, can I ask you, do you, at your institution, do you do daily rounds? And if you talk on daily rounds, what do you talk about? Like, how does this communication occur?
It's a good question. We do rounds every morning in the ICU, and during those rounds, we involve the attending. There's a fellow on the rounds, and then the residents and interns, medical students, if there are students on at that time. The bedside nurse for that particular patient. So we tend to have a 2 patients for each nurse. Ratio is most often what we're using, and so that the nurses all know that that rounds usually start shortly after their shift change, and that they're looking for the team to come by, and they're going to be an active part of the rounds. In fact, and I guess the answer to the rest of your question is we also try to have a pharmacist available every day for rounds. Sometimes we have multiple teams rounding at a time, and one pharmacist available, so they may switch between teams. Usually have a dietitian or nutritionist available. I'd love to have a physical therapist available on rounds. Currently, we have a physical therapist that's covering all the ICU beds plus some additional patients, so they often won't be there during rounds, but are available afterwards for consultation or for discussion of patients' needs.
Right.
But in terms of what do we discuss, rounds most often for a patient are begin with a report from the nurse who will give information about the patient's current status as well as recent notable events. And when they're describing the current status, in addition to giving the vital signs, key points of examination, they include neurologic assessment in their report during rounds. So in our institution, as I said earlier, we use the RASS, so they'll tell what the current RASS is. They'll tell what the target RASS is, which is an order that's in our physician order entry system. And then they'll tell what the patient's current delirium status is. We use this confusion assessment method for the ICU at Vanderbilt. So they're going to report to us the current RASS, the target RASS, and the patient's CAM-ICU assessment results. So are they CAM-ICU positive, indicating delirium, or are they CAM-ICU negative? Of course, if the patient is not accessible because they're currently comatose, which is becoming less and less common, then they would tell us, the CAM-ICU was not accessible because the patient is comatose. But we get all of that information, and then they tell us if they are on sedating medications and analgesic medications, then they tell us about those. If they're receiving an infusion, they would tell us what the current infusion rate is. If they are receiving boluses, then they would tell us, what the order is and when what the last doses were that were given. And if a spontaneous awakening trial was done, then they would have that information. And if it wasn't done, then they would be able to tell us what the reason was for that. For example, if a patient didn't pass the safety screen because they're actively having alcohol withdrawal, then they would say, the patient was assessed for spontaneous awakening trial, but they failed the safety screen because they're actively having withdrawal symptoms. So we get all that information during rounds, and then that's incorporated into the discussion of the plan for the day. If any changes need to be made, for example, if a patient had a target RASS of -3 because they were so severely hypoxemic that we couldn't get their oxygenation better otherwise, and then today the goal may be to change to a RASS target of -1. So we would make a change. We would discuss that on rounds, and then we would make that change. And the nurse, being part of rounds, would know, okay, today the goal is different. And of course, the order would come through as well. And then they would start to make changes to the strategy in terms of treatment to try to reach that goal. How about you? How do you do it in Nebraska?
That's what we're trying to do. The culture when we first started was rounding didn't occur. And so one of the barriers that we faced when implementing the ABCDE bundle was we really had to step back and kind of fix that process of rounding and including everyone that needs to be there. The timing, like you brought up, that there's different teams and how could the respiratory therapist be there when they're rounding with the surgeons and things like that. So really, we spent a lot of effort focused on that interprofessional communication and that rounding process. So basically, what we're aiming to do is what you described, but additionally, particularly when the patient is CAM positive or when they're delirious, we try to then, while we're all in a group, try to figure out why the patient's delirious. So there's an active conversation about, well, what are the possible causes? And like I know you're aware, but more than likely it's either drug-induced or maybe a sign that the patient has a new infection that we're not aware of. Or, they did struggle, like you said, with hypoxia or things like that. So looking at really at the pharmaceutically induced delirium, what the patient's telling us with their change in mental status, are they in heart failure, do they have a new infection or things like that. So we try to address, while we have the whole team there, we actually have the conversation, we try to have the conversation about delirium because that's important. One of the things we found early in the study was, the nurses started to do the CAM ICU screenings and they'd be, they would approach the doctor and they'd say, you know what, patient's CAM ICU positive, and the physician's response would be, that's great, good. And the nurse would try to step back and say, well, no, that's not good, they're delirious. And we didn't seem to do enough education around that, the causes of delirium and the effective treatments of delirium. So now that we're trying to actively incorporate that discussion on rounds.
This concludes the discussion. We would like to thank Dr. Girard and Dr. Balas for their contributions and continued support. Thank you for listening. To receive credit, please complete the evaluation form found on the website www.sedation-cme.org.